For our final presentation of the evening, I would like to introduce Dr. Paul McPherson from Astute Medical. Dr. McPherson will have a presentation about Astute's AKI Biomarker technologies and some interesting data he'll show our group. So Dr. McPherson, please, I'll get you slides.
Thank you. Thank you very much, and thank you for inviting me. It's wonderful to be here talking to a group that is so dedicated to involving the quality of patient care delivery and patient safety. And AKI is a wonderful opportunity to do this. I'm very sorry to see actually earlier on that the AKI rate's gone up. But what we have found with hospitals we're working with is regardless of where their AKI rate, AKI rate sits. So there's some hospital that's been working on AKI for a long time. They've gotten their AKI rate down. They're able to improve it even more. There's other hospitals that have a longer way to go. They're able to improve it as well. So I will show you some of that. A key thing here is not only how to do risk assessment, how to use biomarkers, but how to use that to prevent AKI. It's not advancing. Okay, it seems to be stuck. I have a lot of animation on this too, so it's the problem of slide decks made on a PC put on a Mac, I think. Okay. All right. So I'm a co-founder and chief scientific officer of a company called Astute Medical in San Diego. We started the company 11 years ago. We're now part of a bigger company called Biomarker, headquartered in France. And Astute Medical is the company that discovered and validated and took this test through the FDA that I'm going to talk about. Before Astute, I was at a company called Biosite Diagnostics for a number of years. At Biosite, we were the first company to launch a BNP test. And in fact, when we started developing that test, we had no idea that it was going to be any good, but we developed it and did the trials, and I think everybody knows about that. So this group knows how bad AKI is. It's bad for the patients, it's bad for the hospital, it's bad for the healthcare system, it's really bad for your STS star ratings. And when you look at it, and what's shown on these graphs is the white bars are no AKI, this is stage 2 AKI, and this is stage 3 AKI, which is what you report to STS. Length of stay is higher, and one thing I want to emphasize, even in patients who only get to stage 2, that's a doubling of creatinine. It's not reportable to STS. That's still impacting length of stay. That's impacting your cost, your 30-day readmissions, and your mortality. So it still goes into your STS scores. As far as cost goes, you can look at the average size hospital in the US loses about $20 to $25 million a year because of AKI. So it's pretty easy to get the attention of administrators when you want to do something about AKI. The other thing that I think a lot of people don't realize is, let's take a patient who comes in with creatinine of 1 before surgery. Creatinine goes up to 2.5, so that's a stage 2 AKI. It's not reportable to STS. And then comes back down to baseline before you discharge them. All's good, right? They recovered. Turns out all's not good. In fact, even a transient AKI like that, those patients have higher readmission, they're at higher risk of major adverse cardiac events, higher mortality risk, higher risk for developing chronic kidney disease. So those patients are not okay, and it's very much worth working to prevent this. The problem is, when we look at cardiac surgery, there's risks everywhere. The patients, of course, come into surgery carrying all kinds of comorbidities, chronic kidney disease, diabetes, age, all kinds of things that put them at risk. Some of these patients have acute conditions going on. Once they're in surgery, we have to worry about pump time, we have to worry about hemodilution, all of the things that you know about. It turns out that most of the AKI that develops in these patients either develops intraoperatively or postoperatively. I had a number of questions before the dinner tonight. People were asking me, what about before surgery? What about testing these patients the day before or the morning of surgery? I'll show you some data, but it turns out there really isn't much acute going on in the kidney there. It mostly starts either in the OR or in the ICU afterwards. And we see that this varies. There's hospitals that we've worked with where they have a lot of AKI starting during surgery, a lot post-operatively. There's others where there's hardly any in the OR. Whatever the surgeons and anesthesiologists and nurses and perfusionists are doing, they have very, very low rate of starting AKI in the OR. It's all in the post-op care. So how many people here work in a hospital that's got an open ICU? How about closed ICU? Okay, so if you work in an open ICU and you're in surgery, you own those patients, your PAs, and you have to be aware of this, that this can happen after surgery. If you're in a closed ICU, you've got to work very closely with your intensivists on this and whoever else is managing these patients. I'm going to skip over this in the interest of time. I just said this. If we look at the factors and what causes acute kidney injury to start, there's actually a state that's a little earlier than kidney damage. It's called acute kidney stress, and I'll show you this a little more in another figure. But when acute kidney injury, when acute events start happening, the first thing that happens is the renal tubule cells are under stress. This can be from nephrotoxic drugs, it can be from ischemia if there's lack of perfusion. And if you look at all of the risk factors in the ICU and in the OR, these are the types of things that can cause these problems. So you can have low perfusion, ischemia. One of the most important is actually nephrotoxins. These can be endogenous, so when you do surgery, there's a lot of inflammatory factors released into circulation. These are sometimes called damage-associated molecular patterns, or DAMPs. These, of course, are cytokines and things like that, filtered in the kidney and cause renal stress and ultimately damage. And then there's the drugs, so there's vancomycin, there's piptazo, there's non-steroidals, and particularly with the ERAS guidelines that are saying reduce opiate use, people are using more non-steroidals. Well, those are a problem for the kidney. And so in fact, one of the authors of the ERAS guidelines, Dr. Dan Engelman, says at his place in Bay State, he will not use non-steroidals when there's increased risk. So it's important to know those things. I'm going to talk about the test I'm going to talk about picks up this acute kidney stress. And if the stress is allowed to go on long enough, it's unmitigated, and it's severe enough, this can lead to AKI. And this is what the two biomarkers I'm going to talk about pick up. I'm going to skip over this too in the interest of time. I'll try to get us out of here by 8. So let me serve as an illustration of what happens with these patients and their kidneys and where this test came from. Let's start with a patient who comes in for surgery and Monday morning, presumably with a normal kidney, and has surgery. And the first thing that can happen in a patient that's going to end up in kidney failure is this increased risk. If that goes on long enough, it can damage the renal tubule cells. A number of things can happen. They can have apoptosis, they can go into senescence, they can slough off, all kinds of things. And that may happen Monday afternoon after surgery, it may happen on Tuesday, and if it's bad enough, maybe by Wednesday you'll see creatinine bump, right? Maybe you'll see urine output go down. In fact, the damage has been going on for about a day. And when we started looking at this now about 10 years ago, the thing about damage is there's no drugs to reverse it. So first thing we said is, can we find markers that will pick up early kidney damage before creatinine bumps? But we quickly realized there's no drugs that will reverse damage. There's no procedures to fix it. That's actually too late. And so we actually started looking even earlier. Could we find markers that pick up this acute kidney stress when you can prevent damage? And that's what we eventually, I'll tell you how we found these, but these two biomarkers that are measured by this test. And the test actually combines the result, it multiplies the concentration. So it's a single number, and I'll show you how this behaves. It's a single number that goes up as stress goes up, as risk goes up. So we started out enrolling, the very first thing we did 10 years ago is we said, we know we need very good clinical samples, very good clinical data. So we enrolled patients coming into the ICU, And we wanted a wide variety of patients, because if you look at even cardiac surgery, these patients can become septic, all kinds of things can happen to them. So you need markers that will pick up AKI of very different etiologies. So we enrolled patients that were cardiovascular, cerebral vascular, sepsis, they had respiratory issues, trauma, and surgery. And we enrolled patients coming into the ICU who did not yet have AKI. If they had an overt AKI, we didn't enroll them. We started with a study at 3 sites, 522 patients. What we did was we enrolled these patients, we followed them for a week. We collected blood and urine samples every 12 hours. We collected all the clinical data for a week, and about 20% of those patients developed an AKI, and the other 80% didn't. Those were our cases and our controls. And what we could do is we could pinpoint the day that they developed their AKI. It could be day 1, day 2, day 3, day 4. We could pinpoint that to within a few hours. We could then go back and look at samples collected 12 hours before, 24 hours before, 48 hours before. And that allowed us to look at markers at different times before the actual injury manifested. We looked at a lot of markers. This was a lot of work in the lab. It took years. And this is where these 2 markers came from. We then did a 35-center trial. This was in the US and Europe, 728 patients. We found exactly the same thing. So this was a validation. We developed a clinical assay for this that is now in use around the United States. Then we did a whole nother study for the FDA. So we did a 23-site, 408-patient study in the United States. And we did this one that was 6 sites and 126 patients. So, and went to the FDA and spent 18 lovely months with them, going over all the data. Their statisticians actually recalculated everything, and they eventually cleared this for clinical use. So this test is available. It's been available for a couple of years in the United States. We focused on markers that would detect risk or kidney stress that would lead to moderate or severe AKI, stage 2 or 3, so doubling or tripling of creatinine. And the reason we did that is that's where really most of the bad outcomes were. A lot of the stage 1s, this is a very small bump in creatinine. It can be important, but a lot of it is just pre-renal. We benchmarked these new markers to everything else out there. AUC is not appropriate use in this case. It's area under the receiver operator characteristic curve. And the difference between these and other markers you may have seen in the literature is a huge difference. This is like a 1 second in the 100-meter dash. And again, these are actually the only ones the FDA has cleared. Some of these other ones have been in there 4 or 5 times, and the performance hasn't been good enough. There is a very good mechanism behind these markers, so we didn't just make up that these are kidney stress markers. In fact, although before Astute started this work, nobody knew these markers were important in AKI, we knew a lot about them from cancer research because they are markers of epithelial cell stress, and epithelial cells are what are injured in kidney. We measure these in the urine, and this is what gives them specificity. We don't measure these in the blood because it's the renal tubule epithelial cells that are becoming stressed and injured. And these 2 molecules are released in response to a wide variety of things that cause AKI. The reason these cells release these is it's an alarm signal. They can bind to the cell that released them, and they can bind to nearby cells. And this is basically the kidney saying we're under attack. There's a nephrotoxic drug, or there's lack of oxygen, or there's something. And the release of these molecules puts the cell into G1 cell cycle arrest. That's one of the checkpoints in the cell cycle. That's protective. It's a quiescent hibernation state. And so the appearance of these markers in urine is essentially the kidney saying, I'm trying to protect myself. And this is actually a wonderful time for doctors to intervene and help it along. And we have proof in outcome studies that works. These markers are resident in these cells, so they don't have to be upregulated and then released. We've done a lot of lab work. They're in the cells, and we know that when these cells are stressed, they're released almost immediately. And in humans, you can measure them in the urine within 45 minutes of stress. So they respond very, very quickly when there's a problem. And they're very dynamic, and I'll show you some data on that. We also know that TIMP2 is predominantly released in the distal tubule and insulin growth factor binding protein 7 in the proximal tubule. And it's known that different etiologies of AKI tend to hit one tubule or the other. And that's probably why we basically found through all of our clinical trial work that the two of them together gave the best prediction. And probably the reason why is they're both on slightly different biochemical pathways in this G1 cell cycle arrest, and they're predominantly released by different tubules. And that's why they give good coverage. A couple of things are really important to understand about this test and these markers. This is not a yes-no test, yes risk, no risk. It's a quantitative test. So this is the concentration or the readout that you get from the test on a log scale. This is the risk for stage 2 or 3 AKI. So 0.5 would mean 50% of the patients above here, for example, reach that endpoint. We validated a cutoff in our FDA trial at 0.3. We wanted a very sensitive cutoff that had a very good negative predictive value, because if we said the test is negative, the patient's okay, we wanted to be sure of that. And the negative predictive value is greater than 96%. That's for a single test. I'll show you in a little bit that these patients can have multiple insults and multiple episodes of stress. If you measure the test and it's negative, and then something new happens, that first test couldn't have possibly have told you. There's some new data, though, from Vanderbilt I'll show you. If you do 2 tests and they're both negative, that's now 100% negative predictive value. And one of those was intraoperatively in OR, and one was in the ICU. So I'll show that to you. As far as higher test results, again, it's a quantitative number, and basically the intensity of the intervention, physicians tune to how high the number is, but there is an upper cutoff at 2 that people use, and the risk is greater than 50%. So a number of people who use the test say it's almost diagnostic at that point when you're starting to see those very, very high values. Now, here's something this is a paper that just published a few months ago. And this is an amazing result. So the issue with the kidney, I think probably a lot of you, maybe some have heard the term renal reserve. So we're all born with about twice the kidney capacity we need. And that's very intuitive because we can donate a kidney and our creatinine doesn't go up, right? So we have a lot of reserve capacity. If we eat a huge steak, enough protein, our filtration rate will go up to maximum. So you can measure people's renal functional reserve or their extra capacity by giving them a big protein load. And the deal with kidney injury is because you can lose half your nephrons before you see creatinine bump. When you have patients that come out of surgery and creatinine doesn't change, how do you know they haven't had kidney damage? Because they won't see anything until they lose half. So in this trial, it was, sorry, it looks a little fuzzy there, but at least you can see this. Let's just focus on the left for a moment. What they did is by giving a big protein load, they measured this renal functional reserve, how much extra capacity there was. The blue bars, or the blue box and whiskers are before surgery. The red is 90 days after surgery. So in this one on the left, nothing happened, nothing changed. And these were patients that this test was negative, it was less than the 0.3 cutoff, and they never developed AKI, their creatinine never bumped. So if your test is negative, you don't have kidney stress, and you don't develop AKI, your kidney is just fine 90 days later. There's no damage. You can already see over here it looks a little different. These were patients that had a positive test 4 hours after surgery. It was greater than 0.3. They never bumped their creatinine. They were negative for AKI. Look what happened to the renal functional reserve. They permanently lost nephrons, and you couldn't see it. So this is going to impact these patients for the rest of their life. So in our trials, when we did our trials, we called these false positives because the test was positive. Our endpoint was AKI. There was no AKI. That's a false positive. Turns out a lot of them aren't false positives. And this is very similar. Those of us who have enough gray hair to remember troponin. Before dinner, I was just talking to someone about, we at BioSite launched one of the earliest troponin tests. And our first test, we set a cutoff at 1,000 picograms per mil. Because when we ran our FDA trials, values say at 800 picograms per mil, the clinicians in 1995 adjudicated those as non-MIs. And so we said those are false positives. We need to set a really high cutoff. Of course, we now know those actually are NSTEMIs and ACS and unstable angina. Those are now considered MI. So it's an example of how biomarkers actually change the definition of these things. And I'm going to finish at 8, so I'll speed through some of these. The other thing to know about this test is it's very specific. I won't go over this slide. This is actually in our labeling from the FDA. But if you look at values in healthy normals, subjects with these chronic comorbidities or subjects with acute comorbidities, they look identical. So chronic kidney disease, sepsis, surgery, none of this will elevate the test relative to normals if there's not kidney stress. So if you see it elevated, the only time is in patients who ultimately developed AKI, have kidney stress. So it's very specific. And I want to spend a little bit of time on this one. This is this new data out of Vanderbilt that I mentioned, and it really gives you an idea how this test works. For those of you who know Josh Billings' statin study published a few years back from Vanderbilt, they ran that study to look at statins, but they also collected urine samples, and they measured this test in these samples. And what's shown here, so these are median test values, median nephrocheck values. This is that 0.3 cutoff, this dashed line. You can see the red curve is what the profile, so this is time, I'll go over this in a minute. This is the test profile in patients who ultimately developed stage 2-3 AKI, which was diagnosed 2 days later. So that's pretty typical, right? Creatinine bumps 2 days later. The blue and the green curves are patients who didn't develop AKI or just very minor AKI. You can see at induction of anesthesia, there was no difference in any of these. So even in patients who were going to develop AKI postoperatively, there was no stress before surgery. A number of people asked me before dinner, should I measure your test before surgery? For the most part, no. There's nothing going on. There may be a few exceptions, emergent patients, patients who've come out of cardiogenic shock, but for the most part, there's not much going on. This was 30 minutes after pump was started, still not much going on. This was, so the first time there was a peak here, you can see this is elevated test, this is kidney stress from the OR. This was right when the pump came off, so patients were still in the OR, chest was still open. They see this episode of stress, and this is predictive, ultimately, of developing this AKI. When this is ICU admission, actually I should be using my animation here. This is ICU admission. You can see the test is back down. These patients are being resuscitated in the PACU, and their interpretation, and this is out now, here's the reference, so this is out online. Their interpretation is that, why does this go back down? Well, this is a test that tells you about kidney stress, and if the stress has been relieved, it goes back down. But those patients now, you don't reverse this risk. Those patients are at higher risk. Once they get into the ICU, this is 6 hours after ICU admission, a lot of stress. So this basically bimodal, these two episodes of stress are independent predictors. So when you look at ability to predict they're going to develop AKI, these were statistically independent. That means they are independent episodes of stress. They're not the same episode. And in fact, if both these were negative, that's where they had 100% negative predictive value. So most of the people in the United States who use the test use it post-operatively. They use it here. And they've actually reduced their AKI rate by 30 to 60%. And for hospitals starting out, I think this is what we recommend, and I'll talk a little bit about the things that people do to improve AKI outcomes. But I think we're going to start seeing people looking in the OR as well. And the other thing that's really important to know, this profile looks different at every hospital because it depends on the process of care. So there's hospitals that are using the test and they see huge elevations earlier. There's a hospital in Florida that has been using the test for 4 years. They see nothing here. They're not causing stress in their surgery. And I think a really interesting thing going forward is going to be to understand, what do they do differently, right? All of their issues are post-operative, and they've been able to improve their outcomes. So this is variable at each hospital, but with this test, you can figure out where your problems are, when they're occurring, and where you need to make changes. And we're doing a lot of work with various investigators, both at Vanderbilt and elsewhere, to understand what parameters during surgery are associated with this. So things that we could look at changing. But we do know a lot about the post-op changes. So there's a lot of papers out now on cardiac surgery, this test in cardiac surgery. You may have noticed my title, it didn't say new biomarkers, novel test. It's here now. And in fact, this one paper that I highlighted is routine adoption. It's being adopted in routine. It's at University of Virginia. I'll show you a little bit of their data. And there's outcome studies. So let's talk about the last 7 minutes about how this is being used to improve outcomes. This slide shows, these are all the studies I know about that have tracked of hospitals that have used the test and tracked their outcomes. There's 2 that were randomized controlled trials. And in the interest of time, I'll skip over the details on those, but this was cardiac surgery, this was major non-cardiac surgery. And in both these trials, what they did was they took all comers coming into surgery. Right immediately after surgery, 4 hours afterwards, they measured the test. If it was negative, knowing the negative predictive values like 96, 97%, they said, okay, those patients are not going to be in this trial because the risk is too low. If it's positive, they then randomized them to what their standard of care was and a protocolized standard of care. So in earlier talks, we heard about reducing process variation, reducing variation of care, having a protocol. That's what they did. And I'll tell you in a minute what they mainly focused on. But both of them, you can see the reductions in stage 2, 3 AKI. I mean, imagine a cancer drug that cured 1/3 to 2/3 of the cancer. So these are both published randomized controlled trials. All of the rest are quality initiatives. So these are all customers. There's in Italy, US, this is in France, who brought the test in. And I don't have UVAs up here yet because we're still collecting data, but I'll show you a little bit of the preliminary data. Dr. Tribble says fine to show it. These are all customers who tracked their AKI rate before bringing the test in, put it in place, and did exactly what you all do in a quality initiative, right? They had a protocol, they tracked outcomes afterwards, and you can see the results. These are huge improvements. The amazing thing about this is if you look at the AKI rate they started with, some already had it down to be very low. For example, Health Park, they were down to about 4%. This is Dan Engelman at Bay State. He was down to below 3%. They're still able to reduce their AKI rate. So even people who have their AKI rate that low can reduce it even more. And that's really nice. Again, I'm going to skip over this. You can go read it. This was that Pravaki randomized controlled trial. And the thing that was so important about this, you know, in cardiac surgery, you guys have been improving your AKI outcomes for a while. But when you go talk to intensive care, you go talk to nephrology, there was a lot of nihilism. They said, we can't do anything. The surgeons box the kidney, and then we just can't do anything. And of course, that's not true. And this study, which focused on post-op care in the ICU, so both intensive, anesthesiology intensivists, showed that, in fact, you could improve those outcomes. So, very important study. And again, I'm going to click through all these because I know I'm running out of time, except for to say one thing, because this is very important in what they did, and most of the hospitals using the test and improving their outcomes are doing this. They had a protocol for managing fluids and hemodynamics. Now, you don't have to do this always the same, and there's some numbers up there you'll probably look at and gasp and say, I would never run those numbers. But the important thing is they had a protocol. They had some way of optimizing fluids. They used a pico catheter and stroke volume variations. Other people use Edwards flow track. Some people use Cheetah. Some people use bedside echo. It doesn't really matter. Whatever technique you can make work, but what's important is to have an objective way of getting fluids right. Because too little is bad and too much is bad. And one of the worst things you can do is when a patient is really dry and not peeing is to give them Lasix if they have kidney stress, if the test is positive. Also looking after cardiac index, they used dobutamine. Of course, in the United States, milrinone's used quite a bit. Again, you're going to gasp if you can read this. It says 3. Nobody runs a CI of 3 in the United States, but that's okay. That's what they did. And then mean arterial pressure. They actually did this every 3 hours for 12 hours. They went through. I'm going to skip over that. What I wanted to show you is they did actually make changes. So in their intervention arm, when they had improvements, they gave more dobutamine, as you can imagine, because they were trying to keep cardiac index up. At this particular hospital, they follow the ACC guidelines for restarting ACE and ARBs, so they restart them normally when Blood pressure stabilizes. I know in the States, often they're started later, but it turns out they delayed starting them, and that was helpful. There was a trend towards reducing nephrotoxic drugs. I can see this box has moved, but I want to highlight this bottom one. The other thing they did, they measured this test at 4 hours to randomize. They measured again 12 hours later after that algorithm. And they found in the intervention arm where they had improved outcomes, actually lower test results. And this was statistically significant. The reason that's important is it means when you've done something to help AKI, you can actually see it as a reduction in kidney stress. And now at a number of hospitals, people are using this test not just to say who's at risk and you should do more for them, but to actually monitor the resuscitation. So we have surgeons who are saying, okay, I've stabilized everything, but the test is still high. There's still something wrong, and I need to figure out what it is. Is there a nephrotoxic drug on board that I can alter the dose or get rid of? Is my MAP target not high enough? So people are using it that way. And again, they had a big reduction in AKI. So UVA, we've been working with Dr. Tribble and Judy and their group. Brought NephroCheck in. Their protocol, I think, is really based on this Pravaki study, but you've customized it. You have different targets. You have different ways of measuring things. I know there's other things in your protocol, but what I can say from distilling what everybody's doing, these are two of the most important. And usually when we go into a hospital, the first thing we'll hear is we don't use nephrotoxic drugs. And I think most hospitals we're in, when we actually look at it, most people are. And so Piptazo, Vanc, things like that. This is their algorithm, and using passive leg raise for the fluid part stroke volume variability. You guys, it started in, I think in June, right? June 14. I'm going to skip over this one, but basically their NephroCheck values look very similar to that Pravaki study. So again, I won't go over all this. About a third of their patients are testing positive 4 hours after surgery. About 2/3 weren't. What they did find is at 16 hours, they have more positive patients, so that's something to look at. And the thing about a quality initiative, right, bringing this quality initiative, well, you're not doing a randomized controlled trial. If you see something you can prove, you can go and prove it then, and I think there's a lot of room there. The test performed very similarly, so if both those were negative, 100% NPV. These are very preliminary results. We reviewed at UVA a couple months ago. There's not a lot of patients yet, but I'm just going to go to the summary down here. Before NephroCheck, the stage 2-3 AKI rate's about 10%. That's by no means the highest we've seen. It's by no means the lowest. These were post-NephroCheck, so that's a 64% relative risk reduction. There's not a lot of patients yet, so we don't have p-values and things like that, but I think it's a very promising start. And you know, the other thing about this is, again, you can see where you have kidney stress. Is it getting worse over time? Is it getting better? And that's really what QIs are all about. And I will just say one more thing, and then I'll skip to the end so we can stay on time. Another hospital that's been using this is Bay State. Dr. Dan Engelman, he's one of the key authors on the cardiac surgery ERAS guideline, which NephroCheck is going into. So he's spoken a number of times on this around the world in the last few months. These are expected to, the full guidelines expected to publish in a couple months, and this test will be in there. This particular commentary was actually a commentary they wrote about that Vanderbilt study. And by using the NephroCheck test the morning after cardiac surgery, it's been demonstrated that interventions can eliminate stage 3 AKI. They've practically eliminated their STS reportables. And they did very similar things. They have hemodynamic fluid algorithm. They look after nephrotoxic drugs. They presented this a few weeks ago in San Diego, and very, very nice results. And hopefully we should see their publication soon. So Dr. Engelman loves to talk to people. We were actually hoping to get him here tonight to talk to you, but he just wasn't able to undo it. But he would love it if people call him up, say, how did you do this? What did you do? What's important? I think you guys have talked to him as you had questions along the road, and I think that was very helpful. So a number of the physicians who use this test are happy to talk to people. So, and again, I'm going to skip through their slides. Just a couple things to emphasize. It's really important to get a lot of people involved, particularly if you have a closed ICU. If you have a closed ICU, you really want surgeons, probably cardiology, intensivists, all the advanced practice nurses. It's a lot of work, but when you know how bad AKI is, it's worth it. And what every hospital has told us again, and again, is you have to have the mid-levels, the advanced practice nurses involved, so it really makes this work on the ground. And Judy, you've been amazing at doing that. Most of the hospitals make up a card with a protocol on what to do. It's very important to have that. And this, again, is just their results. They've eliminated stage 3 and greatly reduced stage 2. So again, I'm just going to skip over this to my final slide. Sorry, a lot of animation. So as a result of the published outcome studies, the RCTs, people using this test is going into guidelines. It was out in Europe before the US because Europe is a lot faster regulatory than the FDA. And so these are various European guidelines in Germany. As I mentioned, the ERAS guidelines with Dr. Engelman. This test is going to be in there. This is a group, Acute Disease Quality Initiative. They follow the exact Delphi process we heard about earlier for a number of things, but kidney injury, it used to stand for Acute Dialysis Quality Initiative. They're actually the group that defined your current definitions for AKI, stage 1, 2, 3. They're the group that defined it 20 years ago. And this is a very nice publication. This was a consensus conference from a year ago that just came out this year, talking about cardiac surgery-associated AKI, and it talks about this test as well. And the group here was made up of cardiac surgeons. Dr. Engelman was one of them, intensivists, nephrologists, and others. And so again, using a Delphi process, looking at all the data. So again, the test is here, it's in routine use. And that's it. Thank you.
Two things. One is maybe UVA can share their protocol. That might be helpful. And number 2 is use in post-ACS PCI experience.
That's a great question. Sorry, that's a great question. You know, it's funny, when we started the company 10 years ago, that was our first clinical trial, and we found there's actually a lot less AKI there than we thought. And what I would say, in general, for most procedures, we haven't seen enough patients that have kidney stress to warrant testing. I think there are exceptions. I think there's emergent cases. We're doing a study with a cardiologist, Dr. Lori Daniels at UCSD on this, on high-risk cases for admitted patients. And we are seeing some interesting things there. We're seeing some elevations, up to a day afterwards. Interestingly, we're seeing in those emergent patients, the most powerful prediction might be before the procedure. So patients that go in with high kidney stress have higher 30-day readmissions. There's not a lot of data yet. And she presented that at, I think it was at AHA this fall. But in general, I get the question of should we measure it after the cath lab or right before surgery? We just don't, on the average, see that much kidney stress, and it's not a very productive time to measure. The test works there. Some people who use it will occasionally, if they get a hot case, the interventional cardiologist sends and says, I need you to operate on this patient right now. They will measure it. I was literally sitting in the office of a surgeon in Florida when that happened, and he said, no, nephro check's too high. I'm not going to operate till tomorrow. So rare cases, yes, but for the most part, no. Good question. I may be one of the few people from industry who will tell you when not to use the test, but yes?
How does patient being on a diuretic affect it, since may dilute the urine, and does that shift the curve?
Yeah, that's a great question. So we've looked carefully at that. We've looked at everything from how does urine volume affect it, normalizing to urine creatinine, and there really isn't an impact. And all of the data that we have in our package insert, these are all ICU patients on diuretics, on fluid overloaded, fluid underloaded. There just isn't an impact. So there's no issue with that. But it's a good question. Any other questions? Okay. Well, thank you very much.